Can you just raise hands? Okay, fine. I hope you know all the rules and the time limit. Time is for 5 minutes. So all the best to everybody. Let's start.
We should start now.
So the first presenter, you can tell.
The first presenter is Dr. Sara Razvi. Her topic is exploring post-cataract surgery outcomes, the role of effective phacoemulsification time. Okay.
A very good morning, respected judges and lovely audience. I am going to present my paper on exploring post-cataract surgery outcomes, the role of effective phacoemulsification time. Effective phacoemulsification time, or EPT, is the measure of the actual time ultrasonic energy is used during phaco, and it is implicated in various post-op complications. We wanted to assess the impact of EPT on BCVA attainment time post-cataract surgery, central corneal thickness, central macular thickness, and dry eye syndrome incidence. This was a prospective observational study, and prior approval from the ethics committee and written informed consent from all participants was taken. We assessed 65 eyes of 65 Indian patients aged 50 to 70 years with cataract as per LOCS 3 grading of nuclear pallescence 2 to 4 and nuclear color 2 to 4 grade. All patients underwent an uneventful phacoemulsification surgery via a 2.2 mm clear corneal incisions by a single experienced surgeon. We excluded patients with ocular conditions other than cataract, previous ocular surgeries, trauma, contact lens wear, long-term use of any medications, and any systemic diseases. A basic ophthalmological examination was performed preoperatively. Dry eye assessment was done by Schirmer's test and tear film breakup time. And ASOCT was done to measure baseline central corneal thickness and SDOCT to measure central macular thickness. Post-op assessment was done at day 1, 1 week, 4 weeks, and 16 weeks. Schirmer's test value of less than 10 mm and T-BUT value of less than 10 seconds was classified as dry eye. IBM SPSS version 20 software was used for statistical analysis. EPT in our study ranged from 48 seconds to 1 minute and 54 seconds. Talking about post-op time to achieve BCVA, we divided our sample into 5 groups as per the EPT, wherein group 1 had the least EPT and group 5 had the maximum EPT. And we saw that group 5 took the maximum amount of time to attain the BCVA in the post-cataract surgery period, that is 5.1 weeks. We see an exponential increase in the time taken to achieve BCVA with this graph as the EPT is rising. So we concluded that longer EPT can delay visual recovery after cataract surgery. Talking about central corneal thickness, central corneal thickness increased for all patients maximally at day 1, and by week 4 it had reduced to the baseline values for all groups. However, the maximum increase was seen for group 4 and group 5. We see here in the graph that it's rising for all patients, maximum at post-op day 1, nearing to baseline values at week 4, and the maximum increase is seen in group 4 and group 5. So we concluded that longer EPT can lead to increased corneal edema in the early post-op period. Talking about change in central macular thickness, central macular thickness was maximum at week 4 for all patients. It narrowed down to baseline values, showed a downward trend at 16 weeks, and was maximally raised for group 4 and group 5. We can see in the graph maximum rise at week 4, that too for group number 4. So longer EPT may result in greater increase in central macular thickness during the early post-op period. Talking about correlation of EPT with incidence of dry eye syndrome, we saw that group 5 with the maximum EPT had the maximum incidence of dry eye disease at both 1 weeks and 4 weeks, that is 33% and 24% respectively. The graphs show an exponential increase in the incidence of dry eye syndrome as the EPT is rising. So we concluded that longer EPT may raise chance of developing dry eye syndrome both at 1 week and 1 month post-surgery. Our limitations were a small sample size and a relatively short follow-up period. We also hope to assess the role of EPT across different grades of cataract and pre-existing ocular and systemic comorbidities. In conclusion, I'd like to say that longer EPT is associated with a delayed visual recovery, increased corneal and macular thickness in the early post-op period, and a higher incidence of dry eye syndrome following surgery. Hence, it is important to minimize EPT to enhance and optimize post-op outcomes and expedite the visual rehabilitation. Thank you.
Which machine you are using?
Yes, sir.
Which machine you are using?
Which machine was used?
Sir,
That's
we
the
had the Infinity.
Pardon?
Infinity.
Sarah, I want to ask you, how are you measuring the EPT? Is time the only variable you're using in concluding to these remarks and conclusions?
Ma'am, just
But-
the time. We use the other parameters like were the same for all patients.
No,
ma'am.
my thing is ki there is a parameter called cumulative dissemination of
Yes,
energy,
CDE.
CDE, right? That takes into account the water going inside, the fluids going inside, and the total energy which has been used.
Okay.
So if it's a higher energy but lesser time, that will lead to more side effects, more increase in corneal edema. If
Yes.
you're operating in that dear chamber, you're making the PC safe, but that
Yeah.
might lead to corneal edema and increased CCT.
Yeah, ma'am.
So that those things have also to be taken into
Yes,
consideration.
ma'am.
Have you mentioned the grade of cataract and the EPT?
Yes, sir. Sir, all patients had grade 2 to 4.
2 to 4 is a big range. Because in 4 you may get more, you will
Yeah.
need more energy to.
Yes, sir.
So you
Dr.
cannot
Sir-
compare grade 2 cataract and grade 4 in the same group.
Dr. Sara, the plane of phacoemulsification is a very important criteria for developing a whether it is done in the bag or pupillary plane or supracapsular. You have not mentioned about that factor.
Yes, sir.
Have you considered that?
Sir, it was done the same way for all patients.
That's right, but which way? Whether it was done in the bag
Sir,
phacoemulsification?
in the bag, sir, in the bag.
Or at the capsular level or
Sir, in the bag.
supracapsular level?
In the bag, sir.
And what about viscoelastic which was used? It was
Yes, sir.
visco which was used was common for all cases?
Yes, sir.
Or it
yes,
was
sir.
different according to the grade of cataract?
So same viscoelastic for all
And was it a
patients.
single surgeon who was?
Yes,
Yes.
sir. Yes, ma'am.
So
A
the
single
inter-surgeon
surgeon.
Variability
is
is
also
not
not been taken into consideration.
Ma'am, it was a single surgeon who operated all the cases.
Yes, but there's something called inter-surgeon
Yeah,
variability.
yes, ma'am. That's one of the limitations. Yes, ma'am. Sure.
What's new in this study?
So it's a validation of.
We know that if you take more time, there will be more delayed recovery. So
About the dry eye you have mentioned, have you considered that the shimmers and the evaporative dry eye? Because evaporative dry is very common and the shimmers can be.
So
uh,
preoperative dry eye.
Hmm?
So
But
we
the
excluded
evaporative
patients-
dry is very common in our community. Have you considered that?
So
And the
we-
interpretation of the shimmers test.
So we excluded patients who had dry eye preoperatively.
Okay.
Yeah.
thank you.
Thank you, Sarah.
Before we go to the second speaker, we have a guest speaker. So may I request Dr. Shamit Shetty to give his guest talk.
Hello. Good morning. Good morning for everyone here, and good morning to the chair. Thank you, ma'am. Thank you for the talk for here. So I'll be speaking about monofocal IOLs and what's new in the market right now. I have no financial interest to disclose. So normally the natural crystalline lens has a function of accommodating, giving a good clear vision at all our distance and maintaining our contrast. But now as we age, the dysfunction lens doesn't compensate for the corneal aberrations, but our new IOLs which is there in the market try to, are overcoming this. So we have evolved like from era of PMMA silicon to an era of square edge and aspheric right now. So an ideal monofocal should have give us like a clear optical quality, uncompromised vision for distance, easy to implant, less of our PCO, glistening free, and less inflammation. But again, we ponder over a question like which is the best IOL model, what is like hydrophilic or hydrophobic is best, how do we prevent the PCO, or do we get anything more extra in our monofocals comparing to our multifocals, little bit at least. One of the most common complication we see is our PCO, which is again because of our surgical techniques or the IOL materials which we use. Again, it depends again on the optic size, edge profiles or the haptic materials. Usually a square edge on the posterior surface provides a barrier for our epithelial cells migration by inducing the capsular bend. So this doesn't allow your cells to migrate much, and the sharper end edges are better than that. So glistenings, again, this are the fluid-filled microvacuoles which are there in the IOL polymatrix. So this is less in the hydrophilic ones. The refractive index again. So the more it is, again, the more amount of dysphotopsia which we've seen. So that's why the hydrophilic lenses closely mimic our biological tissue. So they give us better, chances of reducing our glare and abrasions are a little better in here. Aspherics, right now is the idea for aspheric IOLs to return our eye to the normal how optics it was. So now almost all the lenses which we come are the aspherics ones. So this increase our visual potential. I'll just brief something about the models which are there right now in the market right now. So Johnson & Johnson have come up with the new eye hands, which is again the enhanced monofocal lenses. So these deliver around 30% better image in the lower light, and it gives a continuous change of your power from the peripheral to the center. So this creates like a unique anterior surface, which gives you a little bit better intermediate vision, maintaining your good quality of your distance vision. Alcon has come up with their VVT, which is again a non-diffractive EDOF. So this has a stable force modified IOL haptics, which prevention for your PCO and everything. Biotech have come up with their iSert lenses, which are again an advanced monofocal lenses. So they have in that 5 zones in a diffractive segment, and these are a natural yellow hydrophobic material. Rayner has come up with the Ray1 EMV, which is again done in collaboration with Professor Graham Bahet. So this reduces your dysphotopsia, and again this is also one of the new extended depth of lens which are there in the market. So comparing the three, I'm just giving you a normal comparison of all between the three. So Biotech comes from the advanced monofocal. Your Ray1 comes, they market it as a monofocal EDOF. Biotech uses like your wavefront technology. Rayner is using a spherical, decreasing a spherical aberration. And they're giving you a good intermediate at least up to 1.75 centimeters. Zeiss have come up with their monofocal Lucia, which is again a fully preloaded and hydrophobic acrylic. So they have a Zeiss optical concept which decreases aberrations. Again, in their Asphena model, they have the hydrophobic surface with a hydrophilic thing. So this decreases your neural adaptation and corrects that. So your best of both worlds is seen again with the hydrophobic and hydrophilic combined, which protects your PCO, no glistenings, and the hydrophobic surface. So ease of implantation is also in the matter, like which you get most of the preloaded ones, which gives you a no-touch sterility, reduces and quicker this thing. So the future lies in the different shape of materials and the monovision versus the EDOF, and again the light adjustable in the market. So I conclude my talk by telling an IOL is a package of both its physical characters and the material which is used. Despite a long evolution, there is no one clear IOL material which has all the ideal properties. The monofocal plus lens are like trying to give you a little bit more edge comparing to our multifocal ones, giving you an extra edge effect. Thank you. Thank you for your time.
Thank you, Dr. Shetty. And now we will have a second presenter.
Second presenter is
Kanchan Bala. Dr.
Bala.
Kanchan Bala is there?
She will speak on post-operative refractive stats in eyes with PC rupture in cataract surgery in a tertiary care center.
After surgery, but though it has advanced, but even then the posterior capsule rupture is still the most dreadful complication which can affect the visual acuity. So understanding the consequences of PCR on refractive outcome and what management strategies can be done at the time of surgery is very important. So,
Excuse me, can you close the door please over there?
So by evaluating the type of IL used and the adjustment made intraoperative surgery, it provides an insight into optimal management strategies for PCR. So my aim is to evaluate the post-operative refractive and visual outcome in patients with PCR. To study the so the key objectives are impact of PCR, effect of PCR on post-operative astigmatism, the IOL adjustment, and to document and analyze post-operative complication associated with PCR. So it is a retrospective study conducted at Tertiary Care Center. Single surgeon has, these are the case of a single surgeon operated cases. For the duration was 4 years. Inclusion criteria were all the cataract patients. These are the SICS patients. On the patients which we have done SICS and they had PCR. So we have included such patient and who has a follow-up of 6 months at least, minimum follow-up. We have excluded all the other patients. So data was collected from electronic medical records. So pre-operative examination, surgical notes, IOL implanted, post-operative refractive correction, IOL calculation adjustment, all these were recorded. So in case of PCR, the lens were placed in the sulcus or scleral fixation and iris claw fixation. If there was a vitreous was there, the anterior vitrectomy was performed, manual vitrectomy with the help of intercameral triamcinolone. So IOL was sulcus IOL, iris claw and scleral fixated. We have followed the patient for 1 day at first day, 1 week, 1 month, 3 months, 6 months, and 8 months and 12 months. So at the time of PCR, I have implanted the lens in the sulcus. So mostly have used a suture aided in case of a larger PCR rent. So that if the lens, so that there is not a lens is not either placed in sulcus, one is in sulcus or one is in the bag. So that there is an effective placement of the lens in sulcus. And iris claw also with the help of a suture loop I have placed. The advantage is that when we enclave the one claw, at the time of putting the other claw, it can sometimes display, so there can be a phakic or a phakic zone. So to eliminate this, so to aid, actually to help this, I have put a suture loop. Descriptive statistics were used to analyze the data, mainly mean, standard deviations, and frequency. The study was of 65 eyes. So 35 eyes we have applied retropupillary fixated iris claw lens, 29 eyes with PCR and sulcus, and 1 scleral fixated lens. The mean post-operative visual acuity was 612. So the observation time was around 8 to 10 months. The ocular pathologies in which we have applied iris claw and sulcus were like 24 eyes had pseudo-exfoliation syndrome. The second most common was rigid non-dilating pupil. The most common post-operative complication which was there in my study was post-operative hyphema. There was very less IOL subluxation or decentration. The mean post-operative refraction was minus 0.5. This is spherical equivalent in 19 eyes. Next is minus 0.75 to minus 1. So though there is a PCR, but a little bit of the lens correction was like in sulcus, we have deducted minus 1 diopter from the actual lens in intraoperative, and in case of sulcus, in case of iris fixation, minus 1.5 diopter was deducted. So the mean postoperative visual acuity was 612 to 69. The hyphema which was observed were basically because of the iris handling during the iris claw. Because while using the Simsky hook from the mostly when the tucking was done from the left hand, it was a force was more which was causing the hyphema. So a more blunt instrument like iris repositor can help it more to reduce the hyphema. IOL decentration and subluxation were rare in my study, and they were managed later on. Thank you.
So what's your conclusion?
Sir, my conclusion is that PCR are gonna be there in whether, however, we are like a senior surgeon or eventually, but PCR there. But only thing what you have to do, the intraoperatively, how can we manage that thing? How can we place the lens at that point? What correction we can put the lens? Like how much reduction should be there? How much lens, less tilt or decentration?
And manual vitrectomy was there.
Sir, whatever is the best possible availability. But main thing is if like there is no hydration, even there can be PCR, but there is not always that vitreous will prolapse. It is when we go ahead with the surgery and then there's a vitreous prolapse more. So early detection is also important. And in SICS, it is very controlled surgery.
Okay, thank you, madam.
Thank you, sir.
Let's go to the third one.
The third one is safety and efficacy profile of a new design of angular chopper and dialer, to be presented by Professor Dr. Gaurav Kapoor.
Morning, ladies and gentlemen. I'll be talking about a new design of side angle chopper and forward angle dialer, which has been designed by me in the year 2019-20. This was presented at AIC 2020 at the Apple Tree, and it was one of the best 10 innovations which was awarded on the final session and in the free papers and the invited session. The design concept was the best paper in the Cataract session, and it was among the top 5 innovations. The patent was published, and I'm happy to announce the patent has been granted last week to me. So the patent certificate is finally in my hand. Basically, phacoemulsification, we all know about it. What we realize, we've been teachers for so long, surgeon experience is the most important factor. Rate of vitreous complications in various studies is 2 to 14%. And teaching students, we know it's highest with the first year residents and beginners. So that is the bugbear of all the surgeons when you are in a teaching setup. Complications occur in both techniques, either you do the divide and conquer or the chop, but it is higher in phaco-chop. And what has been brought out in various studies is it is highest in unsupervised surgeries. So the supervision is most important. So I took two basic simple design changes in the dialer and the chopper. Aim was to improve the safety profile, reduce complications, increase the efficacy. So in the dialer, I introduced a 110 degree forward angulation. So what this does is, this improves the reach of the dialer in the forward area. So you can go ahead in the nucleus without actually reaching forward. And it increases the tip distance from the PC. And I introduced a side angulation in the chopper, which is 120 degree. Now this was the best axis that I designed depending on the tensile strength of the material. Beyond this, there was breakage. So what this does is, if you go back to your high school physics, what it does is aligns forces. We have been taught in physics, when two forces work in the same axis, their output is much better. There's a cumulative effect. So effectively, when you do surgery at 90 degree or 120 degree angle, your instruments are at an axis to each other. You're not getting the most effective force. So aligning them gives you an addition of the forces. So the idea was to compare the complication rates, phaco times in residents, senior residents and junior surgeons, and in experienced surgeons. So we took all the surgeries of resident. They all done under peribulbar anesthesia, 2.8 mm incision on the Alcon Infinity machine, grade 2 and 3 nucleus. There were 2 groups and there were 385 cases. In senior residents, there were grade 2 and 3 nuclei, peribulbar, transition from stop and chop to direct chop, 1234 cases. And in experienced surgeons, we took all grades of cases, topical anesthesia, 1876 cases. So what is important here is, I'll not go over all the results, is the phaco time and the PCR rates. The PCR rates dropped from 4.78 to 2.03%. So that's a halving of the PCR rate in the beginners. In the senior residents also, it went down from 3.19 to 1.86%. This is because when they shifted to the new design of the chopper and dialer. And in the senior surgeons, obviously we didn't expect much of a difference. Even there was a marginal difference, which was not in the p values. It was not significant, but numerically there was a drop from 0.64 to 0.52% in the experienced surgeons also. So these were the total cases. This is the breakdown of the instruments that they used. This is just one surgery that was done. You can see that the chopper has an angulation of around 110 degrees, 120. So the chopping in a grade 3 nucleus is also absolutely instant. It's an addition of forces that we have done. So the phaco times and PCR rates are in line with the worldwide data. Significant improvement in both in the use of the angle chopper and dialer. It helps in transition to phaco in young surgeons because it gives them the confidence to go ahead with the surgery because you have a safer instrument in hand. Complication rates are reduced and also helps in the transition from stop and chop to direct chop. So to conclude, the chopper has a improved safety profile. It has reduced complications. It helps in the transition to chopping. It helps in hard cataracts. What we actually came out, surprisingly, the best part was the dialer became a chopper replacement because of the design change. You can use it. We did the study on grade 2-3 nuclei, but with experience we have realized you can use it in even grade 4 nucleus with similar results. And so the improved safety is there because you have a blunt tip in a dialer, and it's the ideal instrument for beginners. Thank you.
Thank you. I would like to ask, the purpose of your angle chopper was to go to the periphery.
No, the dialer.
The dialer.
The dialer has a forward angulation. The chopper has a side angulation.
Okay.
So the dialer actually moves away from the PC because it is raised and it reaches to the periphery without your hand actually going forward. So you get a forward reach because of the forward.
Measurement of the keep angulation. What is the measurement?
0.89 mm in the dialer and 0.7 mm in the chopper.
Was it used for direct vertical chop or horizontal chop?
Vertical chop.
Vertical chop. Not you were not.
You can use it in both, sir. We have found it effective in both.
Okay.
So these
But-
are two different instruments, is it? Dialer
Two
is different and chopper
The dialer
is
has a forward angulation, the chopper has a side angulation.
I think in the direct vertical chop it will be helpful, but in the direct
Even in the other,
horizontal
you can
chop,
try it, sir. Now it's this is not part of the project. It's available from Joja Surgical. It's being sold for the last 3 years now. So you can try it out. It's effective in all types of chop. Basic idea is addition of simple physics, like I said, addition of the forces. That is what it does. The dialer improves your reach. That has a different
But
purpose.
in 90% of the cases, you can use standard dialer for chopping. Grade 2 to 3. That
figures
is what
speak-
we find.
I know the figures, but they
It's
speak
the
for
only
them.
5% of cases which are leathery brown.
I agree.
You need choppers.
That's because
otherwise-
we are experienced surgeons. I'm talking from the resident setup. This is where we notice the difference. A 50% reduction and improvement in safety
you
profile
have
is
mentioned
huge.
about PCR, but have you checked about the CCC edge which got accidentally cut?
No, we didn't do that.
There was not a single case where it was
No.
accidental. It may
Such
not have
cases were-
progressed to the posterior
Such
capsule.
cases were excluded because they were taken over by the faculty. These were
But-
successful cases which were completed by the resident from beginning to end,
Okay,
even with
how
the
many
PCR.
such cases were there?
So I have given the figures. They were in
Yes,
the
sir.
presentation,
Okay.
sir.
Thank you.
Basically, the technique, the chopping, the chopper, and it helps more for the beginning surgeons, not for the experienced.
Even for
surgeons.
the experienced surgeon, even in senior residents, we found a reduction in the PCR
No,
rate
no,
and the improvement
for the
in phaco
residents
time.
and senior residents, it helps.
It's a very big boon.
But for the very experienced surgeon, it does not
Probably
matter
for
much.
you and me, it doesn't make a difference.
Mm.
But even I find, I'm used to that instrument, so find it much better as compared to the normal chopper.
Yeah,
and
thank
dialer.
you very much. Next presenter is Dr. Sri Lakshmi. She will speak on visual outcomes of new refractive extended depth of focus IOL, a real life experience.
Thank you. Good morning, respected chair and my colleagues. I'm going to share my experience. I think it's not coming properly. This new implant, extended depth of focus IOL from Bosch and Lam, and it's known as LuxSmart, and I have no financial interest. It's a retrospective study. If coming to the optic principle, of an ideal lead off, unlike a monofocal where there is a retinal blur circle at the retina, this can create a single elongated focus without compromising the retinal image quality, which extends the focus well. So we have various IOL designs, and this particular LuxSmart is based on spherical aberration-induced optic, and it's a non-diffractive hydrophobic preload IOL. It has a read-off center located in the central 2 mm with a combination of 4th and 6th order spherical aberrations of opposite signs, which is important. That enhances the depth of focus. And a refractive zone helps in the meant for the distance vision, and a transition zone which ensures no light loss. This retrospective study excluded corneal pathologies, retina pathology involving retina and optic nerve, and also eyes having astigmatism more than 0.75. So the IOL selection based on Barrett's universal tube taken on IOL Master 700. Varian is primarily used for the incision location. 2.2 mm was taken, and the priming of this IOL is very important. Little BSS injected on either side of the cartridge, and at the tip a little scholastic. Wait for 30 seconds before you implant in the bag. This step is important because it won't stuck in the cartridge. Ensure the centration. In the methods, post-operatively, the visual acuity is assessed for distance, intermediate, near, photic phenomena, satisfaction grade also, and how many of them achieved spectacle independence and contrast sensitivity. The study included 50 years of 35 patients, age ranged from 24 to 75. 22 males, 13 females were included. 43% received this IOL in both eyes and 57% in single eye. The mean pre-op spherical equivalent minus 3.71 with plus or minus 4.2 with a duration of 6 months. 35 eyes underwent femtophaco, 15 eyes underwent phaco, and 5 myopes were included. The IOL ranged from 5 diopters to 24. The 2 cases noticed ERM were not clinically, not affected the visual acuity. The mean EDUA logMAR achieved 0.22. And coming to the visual acuity for distance, 80% were reading 6/9 and better. 6% only lost 3 lines. And intermediate vision, 80% of the reading N6 and 96% reading N8 and better. Neo vision, 76% were reading N6 and 86% reading N8 and better. The mean post-op spherical equivalent was minus 0.73 with plus or minus 4.3. So far, no PCO rate noticed. 10% loss of contrast sensitivity was documented. None of them combined photic phenomena. With 80% of them achieved spectacle independence with high satisfaction rate. Defocus curve assessed bilaterally and majority were reading 6/9. Coming to the literature review, the first 2 reviews studies were compared with a monofocal IOL. This implant achieved good intermediate vision with no significant photic phenomena. 2 optical bench studies both agreed on the fact that it has given good intermediate vision, but the first study says pupil no dependence, but the second study says pupil dependence. Gawaki et al. Targeted low myopia, and in their study, only 25% were required glasses. And but this study happened on, inactive individuals. But my study included many professionals, including doctors, and with mini monovision strategy, this has achieved all the ranges of vision, and without any burdensome dysphotopsia and day-to-day life activities. Thank you.
Ma'am, what is your patient selection for these UV lenses?
They said, various EDOF designs, each surgeon has preference. I chosen all the kind of EDOF IOLs.
Indications and contraindications.
Oh, initially, we have chosen all clean cases, but later on, I started implanting in
I think he's
high
asking
myopes
which
as well.
test you have done.
Test.
Any test was done prior to selection of the patient for putting EDOF lens? Or
See,
you
it's a
just
regular
any
cataract.
patient and you
Any cataract patient asking for some amount of glasses freedom, but as the multifocals, that with
is from the patient's point of view, but from doctor's point of view, did you do any test before putting that lens? Was any test
see,
done?
what test I didn't understand, but then I'm a regular.
We are talking about angle kappa and all that stuff. So
Oh,
was
those
it
things.
checked?
I've taken all regular cases primarily. There were high myopes included, but there's angle kappa because we do pentacam and OCTs, all that. So centration part, I got your question about the angle kappa, but I implanted in high myopes where diopter 5 also implanted, but the outcome was ecstatic.
So what was the highest myop which you have put lens, and what was the power of the IOL?
Power of the IOL 5
Acha.
diopters.
EDOF lens is available in that.
It is available in 1 diopter. 10 and above, it is 0.5 diopters.
And the satisfaction level was checked on any questionnaire or just you asked?
Questionnaire was asked, they are seeing any glare and halos, because there are many, few of my friends who are doctors, so they wanted a read off, so then I choose, and they were saying they could drive well and all that.
Thank you.
Yeah.
Thank you.
One question I have regarding the high myopes you have put these EDOF lenses. You have to be very careful about the angle kappa in them.
That's what the angle kappa was not very deviated. I have to see if there is any deviated angle kappa, then
in the routine
how
case
the
it's okay
centration should be at the Purkinje
high
level.
myopia, you have to be more careful about the implantation.
Yeah, that's true. But eye myopes primarily, it's whether monofocal or whatever. This behaved like a monofocal. That's a reason I have chosen in those eyes also.
Thank
So
you.
the next speaker is Dr. Tejas Sheth.
Good morning, everyone. I am Dr. Tejas Sheth. Today I will going to talk about how can surgical simulator be an effective tool to teach importance of a good grip of holding instruments. I myself am a senior instructor associated with the Help Me See. Help Me See is an international organization offering simulation-based training for cataract surgeries. They have simulators which are high fidelity virtual reality based simulators which are mainly built to support the training for cataract surgeries, and further developments are also on. They have an inbuilt feature to give real-time feedback to the trainees about their performance, and also has a feature to compute each task as a satisfactory or a unsatisfactory based on some specific program parameters. So we actually involved 20 trainees for 4 days SICS course at Help Me See Mumbai Training Center of Excellence. They were demonstrated the task and they were told to repeat the same tasks. The tasks assessed mainly were the tunnel dissection and capsular access. The trainees were divided into 2 groups based on whether the trainee had a good grip or a faulty grip. The faulty grip was mainly the grip which was either very tight or where the distal interphalangeal joints were kept in hyperextension position. These were basically divided subjectively. The number of attempts each trainee required to get the first satisfactory attempt was observed and compared. And the number of attempts each trainee required to get the 6 satisfactory attempts in the last 10 attempts were observed and compared. Out of 20 trainees, 13 trainees were found with faulty grip and 7 trainees had a good hold on their instruments. So you can see on the left side, when we see the central tunnel dissection with a good grip, the surgeon, the trainee easily goes and does a tunnel dissection. If you see on the left side, the surgeon is holding the index finger with the distal interphalangeal joint in a hyperextension position, which tends to depress the heel of the crescent and ends up into a buttonhole. At the same time, when you compare the lateral tunnel dissection, a trainee with a good grip can easily swipe the crescent and get a good lateral tunnel dissection. And on the right side, if you see trainee has a very tight grip, he is able to move the whole wrist and not the fingers. So the whole crescent gets curved and he gets a premature entry. Similarly, when we see the capsular axis, the trainee with a good grip ends up dragging the capsule without any particular complication. And a trainee with the tight grip ends to press on the nucleus while dragging the capsule, which causes a zonular damage. Now here we can see the table clearly says that number of attempts required for the trainees with the faulty grip was almost more than double the number of attempts required trainees with the good grip. And this was statistically significant for both the task tunnel dissection as well as capsular axis for getting the first attempt as well as getting the 6 satisfactory attempts in the last 10 attempts. Our study signifies the good importance of the good grip and faulty grip during the simulated cataract surgery. This aligns with the observation made by Burgess et al. They also noted that different hand positions can influence different surgical outcomes. The observed higher number of attempts needed by the trainees with the faulty grips in our study corresponds with the Burgess et al. Discussion on addressing the M6 learning curve. In conclusion, we believe that our study demonstrates the impact of grip variations on the surgical performance, emphasizing the role of Help Me See eye surgical simulator and objectively assessing these nuances. Having a good grip on instrument allows the trainee to have a better control over the movements. Identifying and correcting the grip in the early days of learning curve is very important, which can help them in learning other ophthalmic surgeries as well. Thank you.
That is a good paper, but what extra information are we getting in this study?
The extra information is basically what happens many times when we are into training. Many times we tend to neglect the grip of the student. So this helps in 2 ways. One is to tell the instructor that you need to focus on the grip of the student. At the same time, the trainee who comes in and sits in the simulator, he understands that if he is going to continue with the faulty grip, it will be taking lots of time for him to understand the small movements and have a good control over the movements.
This is a well-known fact that the grip should be loose. It's already a proven fact. So is there any extra add-on information that we are getting?
The simulators will help the trainee to change the grip and learn it on the simulator rather than doing the same thing on the live patient.
I think there is documentation. So they have shown the documentation, which is an extra thing probably.
Suppose in the wet lab we compare the simulator and the wet lab. Is there any difference in your opinion?
The first thing, the simulation will not give a real life feedback. Let's say we are doing on the goat's eye, if there is some zonal damage, we might not be able to understand, maybe around 10%. We will be able to understand only maybe when it is more than 25%. So we will be able to understand even before the major complication occurs.
Thank you very much.
So the next, Dr. Ankita Sharma, please come to the podium. Dr. Ankita will be speaking on association of serum 25-hydroxycholecalciferol levels in cataractous and non-cataractous patient.
Shall we start? Good morning, everyone. Today we shall go through a study which is of the association of serum 25-hydroxycholecalciferol levels in cataractous and non-cataractous patients who were reporting to a tertiary care hospital in eastern India. I have no financial interest to disclose. So it's a well-known fact that age-related cataract is due to the loss of lens transparency. It can also be because of other factors like micronutrient deficiencies, for example, of essential vitamins and minerals. Vitamin D has been crowned as the sunshine vitamin. It serves a number of extraskeletal and skeletal functions. And the measurement of the level of serum 25-hydroxy vitamin D helps us to know whether the patient is insufficient or deficient. So a value of less than 30 nanograms per ml is taken as vitamin D insufficiency. This is a chart which helps us go through the synthesis of vitamin D in the body. So the problem statement here is that cataract, according to WHO, is the leading cause of blindness all over the world, accounting for 47.8% cases of blindness worldwide. According to the National Blindness and Visual Impairment Survey India, untreated cataract was responsible for 66.2% of blindness and visual impairment in population aged greater than 50 years. The rationale behind doing this study is the antioxidant property of vitamin D, which could help us in prevention of senile cataract by preventing the oxidative stress. The novelty behind this study is that no such study had been done previously in eastern India. So our aim was to evaluate the association between serum levels of vitamin D and the occurrence of type of cataract. And the research objective was to see the levels of vitamin D among cataractous and non-cataractous age-matched controls. So these were studies which had similar parameters and had found statistically significant difference in the vitamin D levels between the two groups. A study by Abdullah et al., which was done in 2019, it had found a difference between the two groups, and also that minimum level of vitamin D is there in nuclear cataract. Also, it found severe deficiency, that is less than 10 nanograms per ml in vitamin in the cataractous patients. So it was a cross-sectional hospital-based analytical study done over a period of 1 year in the Department of Ophthalmology of AIIMS Patna. This was the formula used for sample size calculation. Our inclusion criteria for group 1 was all patients with cataractous lens in the age group of 40 to 60 years. And we excluded those who had systemic illnesses like diabetes, hypertension, hyperparathyroidism or hypoparathyroidism states. Similarly, in group 2, we took controls who had non-cataractous lenses in the same age group and again without any systemic illness. This was the study procedure, followed the entire examination and then measurement of the levels in the biochemistry lab. So these were our outcome variables. Vitamin D levels were measured by chemiluminescence-based immunoassay. Same method was used for serum parathormone. For calcium levels, we had used photometry using Beckman Coulter. The statistical analysis method we used the Jamovi software. An independent t-test was applied for normally distributed and Mann-Whitney U-test for not normally distributed. So in our results, we saw that the morphologies of cataract in the worst size of group 1 had mixed morphology, being of the highest variety. And this mixed morphology also had the highest amount of serum vitamin D levels, whereas it was lowest among nuclear sclerotic cataracts. The mean difference of vitamin D levels between the cataractous and the non-cataractous groups, it was found to be statistically insignificant. Similar results we had seen in parathormone levels as well as for calcium levels. These were the two studies with which our parameters had matched, so we had taken them into consideration. The strength of our study is that still no well-defined threshold is there for vitamin D levels in the serum of cataractous and non-cataractous patients. So if we are able to estimate such a kind of a threshold, then maybe it might help us in prevention. And finding of least serum mean vitamin D levels in nuclear sclerotic cataracts also can help us in associating the vitamin D levels with the type of cataract. The limitations were that ours was a small sample size given the limited duration for recruitment,
And also, high performance liquid chromatography mass spectrophotometry is the gold standard which should be used for the estimation of serum vitamin D levels, but it was unavailable in our institute. That's why we resorted to CLIA. So small studies can, like ours, it can provide significant evidence regarding association between development of age-related cataract and serum vitamin D levels. It's also important to keep in mind the interrelationship that exists between age, serum vitamin D, serum calcium, and serum parathormone levels while we interpret and apply the results of such studies. Thank you so much.
Nice presentation, Dr. Ankita. Dr. Ankita, the vitamin D is not the only predictor for the cataract. There are many other factors which are responsible.
Yes, sir. Even we have
retinal
other
cataract.
antioxidant vitamins like vitamin A also we can see.
No, aside from that, the age changes, the senility, and the UV exposure during the entire life. Those are the other factors which should be considered in such case.
So the duration of sunlight exposure, it can be considered, like how much sunlight exposure was there in the, that we had not done.
I think you cannot directly conclude that if there is vitamin D deficiency, you will have cataract.
Cataract.
That's
Thank you. The next presentation is by Dr. K.K. Mehta, sir. Cyrus Mehta. A new dual pre-chopping technique in flax, far more efficient than regular flax.
Hi everyone, good morning. I'll try to be louder than the other hall. So, for a year or so I've been using a new pre-chopping technique in flax. As you know, I've been doing flax for a few years now. Now, why pre-chopping? Let's go back to a few basics. We know that the main reason for endothelial cell loss and SKs the next day and decompensated corneas is longitudinal phaco and not so much torsional phaco. Pre-chopping isn't new, and Akaoshi had come to India. In fact, he had come to iAdvance nearly 15-16 years ago, and he had done a hard cataract in 60 seconds by doing pre-chopping. So the reason is, the thing is that why aren't we all doing pre-chopping? We all learn phaco chop, but we never want to learn how to do a pre-chop unless we are SICS surgeons. We know that flax causes less endothelial decompensation than phaco. There are multiple studies to show this. This is not really a point of debate anymore. When any new technology comes, everyone says very bad, and in 5-7 years, everyone buys it. So let's have a look at the tools that we are using. So basically, what's the pre-chopper and what's the support chopper? So for the regular flax cases, this is the one I'm using. It has one beak longer than the other, so it gets into the flax tunnel. I don't have any financial interest. I wish I did. They're damn expensive. This is the Rumex pre-chopper. For the harder ones, like a grade 4, grade 5 cataract. And finally, I use something called a ball tip dialer, which is available everywhere. Because this is atraumatic and will never hurt the rhexis margin. Finally, I use a sharp chopper. So the technique is do the flax, rhexis and octants to either levitate on a visco cushion. For soft nuclei, use a ball and get it up. For the hard nuclei, use a sharp chopper. Let's see a video rather than giving all this long talk. So this is what the flax strategy looks like. So all that we have to use the ball dialer on the other side to stabilize. Put it inside and you get 2 splits. For all of us that are using femtosecond laser, unlike marketing hype, we know that we still have to do some separation and chopping. It's not like after the flax procedure, all the 8 pieces are just sitting waiting for you. You still have to separate them. So we don't want to use any additional phaco energy. If you do this right, most of your cases you will end up doing with close to 0 phaco energy. So there are different grades of nucleus. You can see the gas bubble coming forwards. When it's a very hard one, you can visco levitate it and then chop them. you just turn the nucleus around and repeat it. This is another grade 4, grade 5 cataract. You can see the gas bubbles coming forwards. So you have a through and through separation. The new robotic laser systems coming will let us do this in a better manner with close to zero phaco energy. So that's where we are headed today. Thank you. And these are the results where the corneas are definitely clearer, and for Fuchs and compromised corneas we must do it.
This instrument you can use only in flax.
Yeah, so this paper was about that. Of course, you can use pre-chopping. I use pre-chopping for all the regular phaco cases. I never do any phaco without pre-chopping, unless it's grade 1 or just aspiration. Our nice Mumbai cataracts that we have now, we can just aspirate most of them like that only without doing anything. But actually, when there's actually any grade of cataract, I always pre-chop. I never do any cataract surgery without pre-chopping.
Okay, Dr. Cyrus, I have a question. Since in femtorexis, we call it a femtorexis, but it's basically a TOMI.
Yeah.
So once we are dividing with a pre-chopper, is it creating any stress on the TOMI margin?
Not at all. In fact, you'll create much more stress doing it with a regular chopper. Here we are just doing a controlled separation. Just enough the gas bubble comes up. That's it. Then we are done.
And since already the cleavage lines have been made with the femtosecond laser, like then with the vacuum we can just hold the nucleus and divide it with a dialer or a
So in a very
energy.
hard cataract, what happens is that the safety margin is such that there's nearly a 1 millimeter of safety margin behind 1000 microns. So what happens is that the cleavage plane doesn't go all the way through, and in leathery hard cataracts it won't split. You'll end up doing phaco again. So the idea is to avoid doing phaco and to use just separation and aspiration.
Can we call this as a fragment separator rather than pre-chopper? Because you are basically, it's already chopped. The
It's
nucleus is
somewhat,
already
it's
chopped,
somewhat
and
chopped.
You're just separating the fragments.
Absolutely.
So it should be a separator rather than a chopper. Yeah. Thank you. Nice.
Thank you.
Dr. Cyrus, if we do mechanically pre-chop, what is the difference between that and in the flax pre-chopping system?
So flax has the advantage of giving you incision and a rexis, etc. If you're going to do mechanical phaco, of course, I do pre-chop. But here I always pre-chop with hard cases of flax. With the soft cases, again, it makes no difference. Once it's pre-chopped, you just go in with IA and you're done. But with the hard cases, we still do use a pre-chopper.
In the soft case, it will not matter.
It makes no
between
difference.
this technique and the manual pre-chopping technique.
Absolutely.
Yeah, thank you.
Thank you.
The next speaker is Dr. Ashish Bachchao.
Good morning, judges and my dear friends. Today I'm going to talk about a unique trainee survey that we conducted using a virtual reality simulator, which involved in suturing a scleral incision. I am a consultant at one of the simulation development centers.
Yeah. You please speak loudly.
Suturing is the most important skill required in the management of anterior segment trauma, especially for residents when they begin their residency training. It is essential that we teach them to practice suturing well before one goes ahead and does that in real life surgery. However, post-COVID-19, we know there are limited number of eyes and limited number of training opportunities. So how will we help the trainees master this basic skill in suturing, especially in cases of anterior segment trauma or a leaky tunnel wound? With that aim in mind, we went about formulating a questionnaire where we would evaluate the trainee performance on suturing using a virtual reality haptic feedback based simulator, and to identify in the long run if a training course around such a simulation procedure as a proof of concept will help the trainees learn suturing in a better and a controlled manner. With that in mind, we identified 5 trainees who underwent 2 tasks on the simulator, and they received first orientation on the simulation, and then which included theory class orientation sessions and practical sessions on the simulator, which were also instructor led. We focus mainly on 2 basic steps where we know the residents and the trainee find difficulties: passing the needle to the correct depth, involving the correct length from the incision, and tying those knots, especially the 3-1 or a 3-1-1 forward, reverse, and forward technique. And we help the trainees achieve such 25 tasks. We prepared a questionnaire which was filled out by each trainee, which was to know their performance and to know the confidence that they gained after undergoing this surgical training. So this consisted of the simulator, which again has a haptic feedback mechanism. It helps the trainee guide the incision and the exit points and the correct depth of the needle. There are guidelines which helps the trainee know everywhere how much is the depth that they have inserted within the sclera, so that as they practice more and more, it becomes more like a muscle memory to them, so that once all these guiding tools are removed and when they go in real life surgery, they feel much better to continue like that. And the next step that was taught also consisted of making the knots, which involved doing the throws that we do, whether you're doing forward, reverse forward, 3-2-1 or 3-1-1. Those steps were done on the simulator, and then the trainees were given a questionnaire that was filled, which was also objectively assessed. There is an objective assessment on the simulators which tell us the exact depth, the distance where it was passed, and the throws that the trainee did while suturing. We gave the questionnaire and the responses were noted. These were blinded, and the trainee responses were analyzed. We could rate that all the trainees, when they were suturing, they said that they were 100% confident in manipulation of the eye using a colibri forceps, including complications like UL touch. They were very confident. And how would you rate the experience in reaching the correct depth with the needle holder? Almost 80% felt that the depth that they could attain every time while doing the task was good. They were confident, and they were really hoping that they would replicate the same when they go on real life surgery. Tying the knots was a little bit complicated because maybe suturing requires a lot more orientation to do that, but even here almost 80% were happy and extremely satisfied to do that, and most of them reported that they were confident learning these on these 25 attempts and going to suturing. So all the participants felt that manipulation of the eye was as real as in real life surgery. The haptics and the visuals that the simulator offers provides better control of the instruments, and they were happy with the needle depth insertion of the sclera, which was almost 80% realistic as reported in the trainee questionnaire survey. Using the straight or the curved tying forceps did not change much, but we did see a mixed response. And all trainees felt that the simulator was able to alert them in case of complications when the needle goes too deep. It was telling them that it's too deep and you will have a complication going forwards. However, all trainees felt that simulation-based training increased their confidence, and they felt that their skills were enhanced using a virtual reality haptic feedback simulator. So to conclude in our study, the use of a virtual reality haptic feedback simulator affords an opportunity for the residents, the beginning surgeons, to have the feel of a normal tissue without actually spending time or learning those on the real eye and causing complications, but to learn here, have a good muscle memory, and go on the live surgery with confidence. The aim of the study was to impart confidence. It also reduced the learning curve. This was just a proof of concept. We wanted to see whether it will be further done into a training program where we'll have a structure around it. So we are happy that the proof of concept works, and it encourages us to develop a training program around it. And the use of this device in a teaching situation has demonstrated that the instrumentation is useful in learning suturing in case of anterior segment trauma or a leaky tunnel. I thank you for your attention.
That's a good idea. In the present phaco era, most of the people, residents, are not accustomed to suturing, and this is a very good technique to learn suturing. But the important thing is that how much was the availability of the simulator to the residents?
Yes, the availability is an issue. We are a tertiary based center. I'm also associated with the government medical college, so I can have the access for my residents to the simulation based training. It's at a very nascent stage in India. The availability, the transportability, or the logistics of it does not support on a worldwide scale, but bodies like AIOS or Maharashtra Medical Council, Dr. Bhide is also here, support residency training for simulators. So it is picking up. It's very slow, but yes, it can be made available in the near future.
Help Me See should support associations like MOS.
It is very, I think, I will say in a country like India, it is very rarely present.
That's right.
It's a very good paper. It's a good concept. You have shown suturing, but can you have a simulator for trauma cases like corneoscleral suturing? Because the tissue field will be different for cornea and sclera.
So now that the presentation is over and I've declared the financial interest, yes, we are developing a trauma module for learning for the residents, because we see that they don't know how to even handle the needle and do
how
suturing.
to hold the tissue.
Exactly. So we are developing a corneoscleral laceration module soon.
with uveal tissue prolapse.
With uveal tissue prolapse, yes.
Okay, thank you. Good
Thank you.
study.
Thank you.
Thank you very
We now proceed with our next presentation by Dr. Dinesh Kumar Nathalal Maru. He would be speaking on comparison of visual outcomes between ringless progressive IOL and diffractive trifocal IOL.
Good morning all. My topic is comparison of visual outcome between ringless progressive IOL and diffractive trifocal IOL. There is no financial disclosure. Introduction: multifocal intraocular lens in terms of spectacle independence have played very important role in cataract surgery. Nearly all bifocal IOLs achieve distance and near vision, whereas all trifocal IOL achieve distance, intermediate and near vision, but with photic phenomena and compromised contrast sensitivity. This study aims to analyze visual outcome, contrast sensitivity, photic phenomena, patient satisfaction after bilateral implantation of new autofocus pro ringless polyfocal progressive IOL and traditional trifocal IOL with diffractive rings. This study is a prospective non-randomized comparative study. In this study, sequential bilateral cataract surgery by phacoemulsification technique was performed by single surgeon at Asta Hospital Anand between June 2022 to September 23. The inclusion criteria were age between 45 to 77 years, axial length ranging from 22 to 26 millimeter, and predictable post-operative corneal astigmatism less than 1 diopter, and scotopic pupil diameter ranging from 3 to 6 millimeter. The exclusion criteria mentioned in the slides were taken care of. In this study, we have done a comparison of two IOLs. One is the autofocus pro ringless polyfocal progressive IOL, and the details are of this IOL are mentioned in the slide. And the other is at least a trifocal trifocal IOL. The details are mentioned in the slide. The all the necessary pre-operative measures were done. Post-operative examination include uncorrected distant visual acuity at 3 meter, uncorrected intermediate visual acuity at 80 and 60 centimeter, uncorrected near visual acuity at 40 centimeter, defocus curve at 3 millimeter, and contrast sensitivity with palliroption chart at 1 meter, and a questionnaire regarding spectacle independence, photic phenomena, and patient satisfaction was assessed. The results are divided into two groups. The group 1 include 14 eyes of 7 patients received by bilateral autofocus IOL, and group 2 includes 14 eyes of 7 patients received trifocal IOL. The comparative analysis of pre-operative patient demographics between two groups are not significant. This is the graphical presentation of it. Visual outcome 1 month post-op includes group statistics for mean for uncorrected distant visual acuity at 3 meter for group 1 versus group 2 shows better result in group 2. Difference is not significant, and group statistics of mean for uncorrected intermediate visual acuity at 80 and 60 centimeter for group 1 and group 2 shows better results for group 2. Difference is not significant, and group statistics for mean for uncorrected near visual acuity at 40 centimeter for group 1 and group 2 shows equal result in both the group. Difference is not significant. This is the graphical presentation of it. Regarding the defocus curve, significant difference between the group 1 and group 2 defocus curve were detected for all versions from +2 to -4 diopter, which shows autofocus. Group 1 gives continuous range of vision for near, intermediate, and distant vision. And regarding contrast sensitivity, shows significant difference between better results in group 1 with a p-value of 0.001. Regarding photic phenomena was analyzed on 4-point scale. 1 is for not at all and 4 is for severe. The portion experiencing the glare, mild, moderate, and severe was lower in group 1 versus group 2, and experience of mild halos and hazy vision were more common in group 2 than group 1, whereas the experience of starburst, blur vision, and multiple images were equal in both the groups. This is the graphical presentation of it. Regarding patient satisfaction assessment, the performance of night vision and spectacle freedom is better with group 1 as compared to group 2, whereas surgical results are equal in both the groups. This is the graphical presentation of it. In this study, we have a limitation that they are less sample size, non-randomized sample, short follow-up data, absence of certain contrast sensitivity measures, and exclusion of reading speed assessment. To conclude, autofocus pro ringless polyfocal progressive IOL had comparable visual outcome for distance, intermediate and near vision with high contrast sensitivity. It also allowed spectacle independence, glare and halo-free vision with good patient satisfaction. Thank you.
Thank you.
This autofocus is from which company?
It is manufactured by Millie Optics. It's launched in January 2020, 22.
It is totally ringless?
Yeah, it has 3 zones. Upper zone for distance, one triangular zone. The apex of the triangular zone would be in the center, and the lower zone, that is for intermediate, and the lower zone is a wider zone for a near vision. Basically, it's a segmented lens, and there is no light loss in this lens. The available right now lenses, they have a surface modification, either in form of a asphericity or creating a diffractive rings. But in this lens, along with that surface modification, there is asphericity in anterior surface, that is 0.1 negative asphericity. But along with that surface modification, they have made a change in the refractive index, that is called a gradient refractive index technology. In that, the superior part, for the distance, they have hydrophilic material and a refractive index of 1.45, and continuously the refractive index that is gradually increasing to the lower part. The lower part is towards the hydrophobicity. So surface modification and change of refractive index, that focuses and drag the rays from distance intermediate to near vision.
Does it take adaptability for the patient in the post?
I can have a video.
No, adaptability.
Adaptability is good. I have a video of 1 minute, if you allow.
Afterwards, we have 2 more presentations, and I think next session we
just
have
only
to do
1 minute review of the
afterwards.
okay.
Let the presenters present.
Okay,
Yeah,
okay,
we'll come back to you.
Okay.
Thank you.
Thank you.
Next.
So the next presentation is by Dr. Debashish Datta, Negative Dysphotopsia, an Enigma of the Past.
Good morning, everybody. So, negative dysphotopsia, an enigma of the past. Negative dysphotopsia is a burning question. It is ubiquitous to all in the bag lenses. In immediate post-operative period, the literature says the incidence is as high as 12 to 45% and even more. Now, given the number of cataract surgeries done in India and the number of phacoemulsifications done, in the immediate post-operative period, the burden in India is about 8,34,000, and which boils down to about 1,20,000 patients each year, adding to the burden. So there are various management strategies which has come into place to prevent negative dysphotopsia. Reverse optic capture, primary or secondary, and back to sulcus IOL exchange. These are the 2 important things which we do. The aim of the study is to find out the incidence of negative dysphotopsia if we place the IOL in an unique way. So what is that? Let's see. So the sulcus placement of IOL will lead to this derangement of the effective lens position, and centration will be at stake. And reverse optic capture will bring the optic edge out into the below the iris, leading to iris chaffing and release of pigments. So how do we take care of these 2 things? If we can place the haptics in the sulcus and put the optic in the bag, it gives us best of both worlds. So we don't have a pigment release, and the the sulcus is the plane of placement. So we designed a study. It's a descriptive, observational, non-randomized, consecutive retrospective study from April to December 23. All routine cases were taken into account using a hydrophobic intraocular lens placed in the sulcus and ensuring that the optic is aptly captured inside the rhexis margin. Now it's a double masking is done. Even before the patient reports for a follow-up, a telecaller caller calls up the patient on the 2nd, 3rd and 90th post-operative day to make sure whether by giving questionnaire and by asking the patient whether he or she is having negative dysphotopsia. Now, this is a short video whereby you see the first haptic going in the sulcus, the second haptic being dialed into the sulcus, and the edge of the optic is nudged below the rhexis margin. It's a magnified view only. And the edge is negotiated below the rhexis margin. So it's a rhexis capture is done. So this is the post-operative period. You can see the rhexis margin clearly, haptics out of it, optic behind it. The sharp edge of the optic is below the rhexis margin. So it cannot cause iris chafing. The results, it's a cohort comprised of 223 patients, and we found only 8 patients developed negative dysphotopsia. So it boils down to 3.5% vis-a-vis 15 to 45% and even more in the literature. So 1 month post-operative and we are not concerned because anyhow the thing comes down. So what does this study add? The reduction of negative dysphotopsia through strategic placement of the IOL, and future innovations of IOL design and surgical practice can be done depending on it. It has been ignored for long. We tell the patients, it will go off on its own. Don't worry, don't worry. But with the advent of the premium IOLs, everything, if the patient comes on the next post-operative day with a premium lens and says, I see a black shadow, and you are answerable to him or her. So this thing will help in designing of the lens and predicting a better outcome. Thank you.
Thank you. Very good study, Dr. Debashish. So is this study holding valid only for the 3-piece lenses?
You see, at the present, I have done it within the 3-piece lenses. Otherwise, it will raise eyebrows because single-piece lenses are not allowed to be placed in the sulcus. So for this thing being proved, then we can go on. Like trifocal lenses, multifocal lenses, we used to have rezoom lenses, multifocal lenses, multi-piece multifocal lenses. So then we can venture into all those things.
A good sample size and statistical analysis. Thank you.
Have you compared with the, suppose we are using piggyback lenses in the negative dysphotopsia?
Those are the, yes, options, yak capsulotomy, truncation of the nasal edge of the lens, piggyback lenses in the sulcus, all these things are, but this is anybody anywhere can do.
But the limitation to this is that the single piece lenses at present.
That's why I said we can take into consideration the design thing. If this is proven, we can design those things with the single piece lenses or proper haptic design with the proper optic.
Thank you very much.
Thank you so much.
The next presentation is by Dr. Sapnil Kothari, and he would be speaking on Precision Toric, novel AI-based indigenous cost-effective toric guidance system follow-up study.
Good morning. Myself, Dr. Sapnil Kothari. I'm the presenting author. So this is about Precision Toric. We have a financial disclosure. Authors 1 to 4 are directors, and author 2 has no financial incentive. As we know, 25 to 30% patients have a corneal astigmatism more than 0.75, and our options are either toric or LRIs or OCCIs in some cases. Now the problem with toric IOLs is manual markings have a spread and fade, accuracy is a little less, and they are cumbersome to do, while automated devices are significantly costly and fixed to one microscope. So we ourselves invented a toric guidance system, which is Precision Toric. It's an indigenously developed and extremely affordable system. We using the off-the-shelf components and uses advanced self-learning to guide you during your surgery. The aim of this study, as it is a follow-up study, was to validate the accuracy of Precision Toric in live patients, and it was a non-randomized, dual-center, non-blind study. We had 49 eyes of 36 patients, out of which 19 were males and 15 were females. The age group was 46 to 76 with a mean of 62, and we chose only non-complex cataracts with a reliable preoperative topography to be included for this study. The method of using Precision Toric is you can do a random ink mark at any location, and then a baseline photograph of the patient is taken with the Precision Toric software, which is an Android software. Here the head tilt has to be kept a minimum. I would like to address Dr. Bhidesa. This question was raised to us during our previous study, and we did study the effect of that. So the head tilt has to be kept at a minimum, and the photo is uploaded to the server over Wi-Fi, and the baseline photo is processed by our software, which is a computer-based software, and in which you have to basically input the toric IOL location and the incision location, and then it processes that image, reverse calculates everything from the ink mark, and gives you a live guidance. I have a video, but due to time constraints, I'm not showing it here. And then the software processes everything, and it gives you the live guidance of where your ink mark is and where you're supposed to place your IOL. Coming to the results of the study, all eyes, the limbal and ink mark location was satisfactorily depicted, found out by the software, and ink mark augmentation was required in 2 eyes. Coming to post-op IOL position, we found a mean of 3.2 degrees, that is 1.125 degrees from where the post-operative slit lamp measurements were done, and the average post-op refraction at 30 days was within 0 diopters to 0.5 diopters of cylinder for all of these patients, with a spread from 0 to 2 cylinder. This 2 cylinder was in a patient who had a 12 diopters astigmatism, and the IOL actually could not be made available. So coming to the limitations of our study, it's a small sample size, and the slit lamp method to check the post-operative position of the IOL is actually not very optimal. Eye trace provides a better accuracy, but we don't have access to it. Coming to the conclusion of our study, we would like to conclude that our system provides a reliable, accurate, and easy and cost-effective method for toric IOL positioning, which can be utilized, and it requires further evaluation for guidance in a larger sample size. Since I have time, I'll just try and show a video. So basically the system tracks the ink mark. It tracks the ink mark, and it gives you a live guidance when you're operating of where your toric IOL is supposed to be placed. Thank you.
So could you please re-explain the how AI is functioning here?
The AI is used to find out where the ink limbus is. We have trained it on a large data set, so it finds out where the limbus is, irrespective of whether you have a pterygium, you have a corneal scar, and it also is used to track the ink mark in real time. So basically what we are doing is we're taking the baseline photo. From the baseline photo, we are finding out where your ink mark is. Then this again finding out is being done by AI. So the AI is tracking the ink mark, the AI is tracking the limbus, and from both of these, it is recursively giving all the calculations. The calculations are mathematics, and it doesn't require any AI, but tracking the limbus and tracking the ink mark in real time requires an AI.
So you mean this is more like a Varion or a Callisto, but with the help of a smartphone?
Not a smartphone. Smartphone is utilized for giving you the baseline image. So for Varion or Callisto, you require either the Varion base unit, or for Callisto, you require a IL Master 700. For our software, all you require is an Android phone. So the Android phone will give you the baseline image, since you have to know the location of the ink mark pre-operatively for you to track the ink mark intra-operatively. So we are using a smartphone which is very widely available, just cost you 15,000-20,000 rupees. And later on, when you are operating, the whole thing is done by the AI. So that requires a dedicated computer with high-end graphics cards. You have two ways of tackling the problem. Either you can brute force it through AI. So AI is actually a brute force method, or you can have dedicated hardware to track the limbal vessels and the iris anatomy. The problem with that is that requires a very high level of hardware integration, which increases the cost to what Varion or Callisto are charging.
Okay.
So to decrease the cost to something which can be utilized in any operation theater, we have gone with the AI method.
Good innovation.
What is the sample size you worked for?
When we submitted this paper, the sample size was around 49 eyes. Right now we are at around 87-90 eyes, and the data is consistent.
And what is your precision level? What is the residual astigmatism you've seen?
0.5 to 5, 0 to 0.5 cylinders post-operatively.
The calculations have been done on?
All the calculations are as per your routine calculator. We don't have any calculator that we have developed because it's available anyway for free on Barrett's or Kane. So you can use any topographer that you have and which you are comfortable with. You can use any calculation method that you already have or you are comfortable with. There's no point in us developing this thing which has been already done by someone else and available for free.
Thank you very much.
Thank you.
Time
Thank you.
is over, ma'am. Thank you.
Thank you, sir.
Thank you all the speakers.
Thank you all the speakers, and we'll have a quick group photo with the speakers.
All the speakers are requested to come to the podium.
We'll have a group photograph. Please come.
Please come. Yes. All the speakers.
All the speakers.